Dr. Sabrina Siegel with the Neuroscience Education Institute, and twice a month, I sit down with a renowned mental health care expert to discuss breakthroughs and best practices for treating patients with mental illness. In this episode of the NEI podcast, I have the privilege of interviewing Dr. Christina Gerges about gender disparities in the mental health profession. She is a psychiatrist and associate professor of psychiatry at Loyola University, and she is also the medical director for the Consult Liaison Psychiatry Service at Edward Hines Jr. VA Hospital in the suburbs of Chicago. She is also the founder of Psychiatry Network Facebook group, which has over 11,000 followers. Welcome, Dr. Gerges.
Thank you so much for having me. I'm really excited to be here today and chat with you.
Me too. Dr. Gerges, could you share with us some current statistics on gender disparities in psychiatry?
Yeah, so gender disparity is a continuing and ongoing issue in medicine and in psychiatry. And unfortunately, when you try to parse it out specifically in psychiatry, it's very difficult because the data is just not there. We do have a lot of data regarding gender disparities in medicine. And the data that we have for psychiatrists show that we're kind of on par with all the other medical specialties. So now is a time where you may have heard this statistic being thrown around that for the first time ever in history, women are making up half of medical school classes, whereas previously, of course, it was less. And so everybody's very, very excited about this. And this is such a great thing. The only problem with that is that already after medical school, there starts to become a drop off. And so you just start to see women physicians not stay in medicine, right? So even within residency, there's less than 50% of women working as residents. And then when you get to after training, it's something like 38%. So under 40% of the active physicians in the United States are women. Wow. So it's great that we have that many women medical students, but clearly there's something lacking where we're not supporting those women to stay in medicine afterwards. Another thing that we look at in terms of, are women equal to men in medicine is leadership, right? Who makes up our leaders? And if you take a look, like, for example, deans of medical schools, only 16% of deans are women. If you look at chairpersons of departments, and this is, again, any specialty, 13% on average are women. In psychiatry, even though psychiatry is one of the specialties where women and men are about equal in numbers, we still only make up about 31% of chairmen of departments of psychiatry. So we're not representing like our full numbers. So there's also been research on things like how are women treated within medicine, right? So, for example, one interesting study that was done a couple of years ago was looking at whether women versus men are called by their first name when they're being introduced for a talk. And women tend to be called by their first names. And really, anecdotally, if you talk to most women in medicine, like any specialty or any discipline, you'll find that. And I can even tell you, I had an email like a month ago, maybe or so, where the email said, "Oh, Dr. So-and-so, Dr. Smith is going to do this and Christina is going to do that." And we both essentially have equal position.
Right.
So, and it's honestly like it wasn't even upsetting to me because it's not done intentionally. This actually came from a woman. And I think it's just very, like for example, if somebody's talking to you about their doctor, like I've made this assumption that the doctor is a man, so it's just kind of what we've been trained to think is that doctors are men. And so I could go on and on about the types of gender disparities, but those are the big ones.
Right. What specific issues do female nurse practitioners or physicians treating mental health face in the workplace?
So I like to break it down into two separate like issues, right? So one is just being a woman. Women face gender bias, they face discrimination, and they face sexual harassment. It doesn't matter what field or what specialty. I know women in the legal field and the business world, and they sometimes have worse stories than I think the stories in medicine are terrible, but they have, pretty bad stories too. So just as women, we're already going to have some of those issues. And then secondly, now, if we're looking specifically at being nurse practitioners and physicians, we're in a unique position. We can be harassed by our superiors, our colleagues and staff, but now you have this extra population, right? So you have patients and their families. Mm-hmm. And that's one of the reasons that medicine tends to be a little bit worse off in terms of gender bias. There was actually a study, I would say it was a landmark study per NASEM. NASEM is the National Academy of Science, Engineering, and Medicine, and it was done in 2018. And it really just looked at all the literature and all the research that had been done up until that point and summarized it. And one of the big things that they found was that medical trainees are more likely to be sexually harassed than students in engineering, research, and science. And, the theory was because of this issue of having this additional population that could harass the trainees. And then secondly, also, there was a little bit of a discussion about the culture of medicine, which is very traditional at a lot of places still. Mm-hmm. Now, in psychiatry, on top of all the things we just talked about, we also have the issue of working with patients, sometimes with psychiatric illness, dementia, delirium, substance use. And so it makes you think, like, do we actually face more sexual harassment than other specialties? It's actually hard to say yes to that because the data is just not there. Again, anecdotally, you hear these stories about patients, but you hear some of the same stories from physicians in other settings, like emergency room settings, I think have the same type of potential issues with patients that may be a bit disinhibited. And so in any case, it's just hard to say whether it's more or less, but if nothing else, it's at least similar to everybody else.
Wow. So thank you so much for sharing that with us. So we know that your chapter on sexual harassment in burnout in women physicians was just published by Springer today. Congratulations.
Oh, thank you.
Can you share some research findings with us on sexual harassment toward women in the mental health profession?
Sure. Yeah. So I can even tell you stories that I've personally experienced. And one of the stories actually that it's just such a poignant story for me because it happened in my first month of residency. And I was on the inpatient unit where I was taking care of, patients with all kinds of issues. And one morning I was rounding on my patients by myself without my attending. And I walked into the patient's room and he just did not want me in there, didn't want to talk to me. I told him we still needed to talk because we needed to figure out disposition for him. And he called me baby girl and told me to get out. And, it's kind of amazing because at the time I did not have the language or the words to respond properly to that. And I still kind of regret it. I think back, like now, if that had happened to me, I would be able to say something to the patient about how that's not an appropriate way to talk to me. But at the time, nobody had taught me, warned me. And I actually never even told anybody. I never told my attending, but I still remember it. And so, we know it happens. And having a lot of friends in psychiatry, I have heard many stories from them too. There is one older study that showed that up to 80% of psychiatry residents have dealt with sexual harassment in their training. Now, like when we're looking at like more current data, we see kind of a wide variety, anywhere from like 30% to 80% of women in medicine, including psychiatry and mental health, are sexually harassed. One of the problems with some of these studies is the way that they ask these questions. They ask, so some of the studies are only like 30% because they included sexual harassment as part of, general abuse in training, so that could be one problem. Another issue is this issue of ambient sexual harassment. which is not having the sexual harassment happen to you, but witnessing it or, being in the vicinity of somebody else being sexually harassed. And most people don't even know or consider that to be sexual
Right.
harassment. So when they answer the question, they'll say, oh, I've never been sexually harassed. The studies that ask kind of a generic, have you ever been sexually harassed? Those studies tend to have lower numbers than if they spell out exactly what sexual harassment is. Is it somebody whistling at you, like, asking you out on a date, touching you inappropriately, etc.? Those people tend to respond more positively too, because you're being specific.
That makes sense. Wow.
Yeah.
Yeah, good to know. Would you say that this situation has improved over time or gotten worse? And what are some of the factors that might be contributing to this?
Sure. Unfortunately, the situation has minimally improved over the past 30 years. Yes. So, I mean, if you point to, do we have more women in medicine? Yes. Women in medical school? Yes. But is it adequate? No. And, certainly especially after training, we are losing some of these women. And so the cultural issues within medicine are really affecting things. Medicine is a system that is set up for men, particularly for women who are mothers. It's not a friendly system. And it starts from having to work extended shifts in the hospital, lack of time to pump, lack of pumping locations.
Facilities, yeah.
Yeah, no flexible scheduling. Those are things that would be helpful to women and that generally male physicians tend not to have a problem with. And actually, there's data that shows that male physicians and scientists are more likely to have a partner who's at home to help them than women. Women tend to usually have a working partner. And so,
Interesting.
so for men, sometimes they're more able to attend late night meetings because there's somebody at home taking care of the kids or working longer hours or taking leadership positions. This is one of the big places where medicine needs to change. And then the other big issue is sexual harassment. So sexual harassment continues to be a problem because whether it's a student, a resident, a nurse, or a physician, by and large, almost everybody, when surveyed about this, will tell you that they are afraid to report anything, particularly the lower down in the hierarchy they are. So medical students are terrified of getting kicked out of medical school or getting bad grades or not getting good letters, things like that. And there's actually been stories like that, both in the news and social media, where somebody has reported something. There was actually a story about a male physician in Illinois a few years ago who was fired for essentially being a whistleblower about sexual harassment. So these are actually real fears that people have. And then the other thing is that institutions still do not really, I would say they still do not adequately take a stance on sexual harassment. One of the things I found in my research when I was writing that chapter that you mentioned was that ACGME takes a very strong stance for residents regarding fatigue. They've got multiple policies. They mention it in different places on their website. They have several requirements about the type of education that we have to give residents to teach them about fatigue. We can't overwork them because of the fatigue issues, etc. When it comes to sexual harassment, there's a one-line statement that just says that the program has to have a sexual harassment policy, and it may be the larger institution's policy. So programs don't even have to have anything specific to residents. They can just adopt the hospital policy for sexual harassment.
That seems crazy.
It is. I had to read it a few times to make sure I was reading it correctly. And same thing, there's an organization for medical schools. That's the same thing. Fatigue is very highly addressed versus sexual harassment very minimally addressed. So,
wow.
Yeah, these are things that we would love to see change.
Yeah. And how much do you think not just implementing sexual harassment training, but maybe implementing education for women in terms of how to address sexual harassment or how to handle that, sort of like you were saying in your early years in the beginning of your residency, Do you think that type of thing would be helpful to women so that they know how to handle that? Because like you said, if it was just not even addressed at all from both sides, do you think that could be helpful?
I'm glad you asked that. That's a great question. So I've been looking at this issue for almost 10 years now. And initially, I was just kind of collecting information about sexual harassment, like data, and kind of understanding it. And then in the last few years, I've moved towards finding a solution. So
Right.
one of the solutions I came up with in the past couple of years is that I do actually have a specific training that I give to residents. Sometimes I presented at the American Psychiatric Association last year at their May meeting and presented basically where we give information about sexual harassment and then have the participants do some role playing. It doesn't substitute for all the larger changes, institutional and systemic and societal changes that need to happen. But it is, I think, at least a small part of it. I'll give you an example. One of the first times I did this, the resident told me we were doing the role play part. So it was just a resident in front of, 4 or 5 other residents. So very small group. And she said that the patient held her hand, like shaking her hand, but then wouldn't let go. And so that's what I did. So I grabbed her hand. I was holding it, like shaking it, wouldn't let go. And she still could not say anything. She froze, even in the role play, And so she's like, what should I say? And I said, oh, well, you could say, please let go of my hand. This is inappropriate. So I actually made her just repeat those words just so that she has those words to use if something happens again. But it shows you, like, even the most basic things, like, we sometimes just don't know how to do unless we go through it first.
Right. Absolutely. Yeah. I think that's so powerful. That's great.
I also came up with a mnemonic, which is nice try. Really, anybody can use this, right? It doesn't have to be like in medicine, but where people can go through step by step, like the N is for notice, like notice if, something is unsafe or if the patient is sexually harassing you, and then all the way to NICETRY, nice try. And that way you kind of have like a framework of how to go and how to talk to the patient or how to deal with the situation.
That's great. I love that.
The whole thing is actually listed out in the chapter if anyone's
in the chapter. Okay.
Yeah.
That's great. And we will have a link to your book in the show notes. So what types of discrimination do women face mostly in psychiatry, and what can be done to combat this? I know you touched on this a little bit, but could you expand a little more?
So I want to say psychiatry is no different than other specialties. Even though our ratio of women to men is generally like a 1-to-1 ratio, we still have these discriminations and disparities. And one of the big ones that I think we need to address and talk about just even right now is pay disparity, right? So we're talking about thousands and thousands of dollars in the differences between men and women's salaries. And this is both in medicine and outside of medicine. And so there's been critique of the data. Generally, I mean, if you pay attention to who's doing the criticizing, when I give this information in talks and things like that, it's generally men critiquing it. But the data is self-reported, right? So it's not the best data, but there's so much data that shows that the consistency that for the same amount of work that's being done, women make less than men. They prorate for the number of hours worked and for leadership positions and things like that. And despite all of that, women are still making less than men. And so unless you know exactly how much money everybody in your department makes, it is guaranteed that you are making less than the men in your department.
Wow.
It's guaranteed. Yeah. I will tell you that this was, maybe 5 years ago or so, that everybody in our department just received a raise. And my supervisor took me aside and said, your raise is going to be a little bit higher than other people's, like if you happen to talk to anybody. And it was because I was making less money than the 2 men that I was supervising. And I was supervising. So it was really great that my department caught it. My department corrected it, but it had been going on for years. It's just like every 4 or 5 years, they kind of go through and like try to equalize everyone's salaries. But the same thing happened. The same thing happened. I was told, that my raise would be a little bit slightly different because, again, I was making less than I should as a woman.
Oh my
So
gosh, that's just crazy.
it is crazy. Yeah, it is crazy. And I would say like my department's like really great about making sure, well, I work at a government institution. So actually everybody's salaries are public information. So there's
Oh,
some transparency to all of this.
right,
Yeah.
right,
So, but even with that transparency, I mean, I'm not constantly checking my salary, so
right.
I really realize like when it's happening.
Yeah. And now that you say that, I've heard it said that some people have argued that it's not that women make less than men, it's that they don't speak up in terms of their salary or ask for raises as much as men do. How much do you think that there's merit to that?
I mean, I do think that there's some merit. I don't think that that's the entire reason because you also hear of a lot of stories of women who do ask and get told no.
Mm-hmm.
But yeah, I mean, if it's still kind of a terrible thing that if two people are applying for a job and the man is, I mean, okay, Sabrina, actually, this happened to me too. Okay. So when I first started my job 11 years ago, I applied at the same time a male psychiatrist was applying and he ended up negotiating his salary like an extra, I don't know, I think like, let's say $5,000. So he already from the beginning was going to be making more money than me, even though we had equal positions going in. And so at the last minute, they told me that I was not going to be getting some student loan repayment that they had initially promised. And so then I said, oh, well, how about we adjust my salary? And so then they gave me the same raise that they had given him. And so we were kind of on equal footing. But if I hadn't asked for that, I know that that would not have been given to me. So it's
Wow.
kind of terrible. I mean, people will say, well, I mean, we'll pay people like what they will, work for. So if
Right.
we're not going to pay them a lot and they're willing to work, then what's the problem? But
Mm-hmm, mm-hmm.
it's discriminatory. So
Right,
it's
right.
really not the right thing.
Yeah. No, it's crazy. And I think we do need a lot more awareness about this issue.
Mm-hmm.
What other types of discrimination can you touch on that women might face in the medical field in general? So we talked about salary, but what else?
So sexual harassment is really a big one. There are some men that also experience sexual harassment with female patients and sometimes male patients, but that is a very small minority of the sexual harassment that's happening. And I think for women, especially, they can be more vulnerable to harassment if they are in like private sessions with patients, sometimes on the inpatient setting, like we talked about with disinhibited patients. So those are pretty common. And then finally, one of the things would be, I would say, departmental issues, right? So, for example, I hear like women who have trouble attending meetings because people are putting the meetings like right at 5 p.m. Hard for them to go to that meeting or 7 a.m., right? When they're the ones getting the kids ready in the morning. I read something on social media recently where a woman was saying that her department was requiring like a Zoom meeting on Sunday nights. And she stepped up and said something, but the problem was that most of the people in the department didn't feel like that was a problem, except for the moms.
Right,
Right? That's
right,
family time
right.
for some people. So it depends a lot on the culture. I've also heard like things where some places have a great family culture, but they have to be willing
Yeah.
to really look at what women need and offer it to them and support them when they need it. Like something that can be really helpful for women would be different types of scheduling, for example. So, like a compressed schedule where they work all their hours, but in 4 days instead of 5 days a week. So they have one day
Oh,
off. That could be
yeah,
helpful.
yeah.
Or, working maybe some non traditional hours, like once a week, so that they have like extra time. Or one of the big things, we actually posted a survey a couple of years ago to women physicians at Loyola. And one of the things that really struck me was I think somewhere between 30 to 40% of women were not using all of their vacation time
Oh,
because they were concerned about coverage. It
yeah.
was Yeah, so they couldn't find anyone to cover for them. They also would comment that in their department, like nobody takes vacation. Like it's again, like culturally, like it's frowned upon if you actually use your,
Right.
your
Yeah.
vacation time, things like that. So that's really sad because that's at least a benefit that people have access to. And in medicine, sometimes they don't. You know, we also feel guilty sometimes about
Yes.
leaving our patients, especially if the coverage is not going to be, it's never going to be as good as you are, but with your patients. But yeah, so it's a lot of complicating issues, I think.
And so along those lines, what are some of the work-life issues that women face when it comes to trying to balance a career in medicine with family?
I will say this is why I think my perspective on this topic has changed because, 10 years ago, I wasn't married. I didn't have children. And so I was focused more on sexual harassment and actually the specific area of patients sexually harassing, their clinician. But over time, things radically changed when I became a mother. I had my son about 3 years ago, and I had to navigate some of these things. And I also started listening more to what other women are going through. So when I hear about, younger women, teenagers, college students, like talking about these things, I think it's so amazing because I never, that kind of just like, went over my head until just a few years ago. And so the biggest issue I think we have to talk about is the mom issue, right? So women in medicine, first of all, are putting off having kids later in life, right? So after their school, after their training. Another like rarely discussed issue is that later in life, they may be facing infertility issues, which can be costly, time consuming. It's disruptive. It's disruptive to work, emotionally difficult. So that's even before you have kids. Then once you do have kids, the first issue that comes up is the question of maternity leave. Sometimes there's a pressure not to take too much time off. People in private practice, I've heard of just taking 2 to 4 weeks because of the lost income. And then a lot of times with larger institutions, it's not fully paid. That it's paid, but it's not paid at your full salary. Or sometimes you have to make up the call that you're missing during your maternity leave during the rest of the year. Meaning either you're doing it while you're pregnant or you're doing it after you come back from maternity leave and you're exhaustedly like taking care of, of an infant and taking extra call in. And so all of those are problems. And then sometimes, of course, the issues of not wanting, again, to leave your patients or having your colleagues cover for you because it can be kind of tough. And then when they go back to work and want to breastfeed, so many stories about difficulties that women have with breastfeeding. So if you're lucky, like you have your own office and you can pump there, but sometimes, the place that you're working for won't give you extra breaks for that, or they say that you can have the breaks, but you have to make up the patients after, at the end of the day, which is, I would say, like pretty exhausting. And then, of course, like the huge issue of childcare, right? So, which is expensive. It's sometimes unreliable. Women tend to be the ones who are taking time off of work when their children get sick. And a lot of places just don't want women to work part-time. So some women actually feel forced or feel compelled to leave medicine altogether and maybe return when their children are older. Or they stay, but they don't have that flexibility that we were talking about, which can be helpful. This actually kind of feeds into the leadership issue that we discussed. So it's hard for women to take on leadership positions because of the extra time requirements, or even to be considered for the positions because they're not able to stay for these extra meetings. So then they don't seem like a team player because they have to go home and take care of their families. Something I've heard where I'll be in a group discussion and we're talking about who can be appointed to this committee or that committee. And sometimes someone will say, oh, so-and-so wouldn't be interested in that committee. She's got kids. And, I think it's a well-meaning statement. I don't think it's, said out of malice, but I think that we really need to give women the option themselves to say no to that because we don't know.
Yeah, I've worked at places where they're not even supposed to ask personal questions like that. I think to be somewhat protective of a woman in terms of whether or not an opportunity comes up. But I've also worked at other places where that's not the case, like you said, and it's not always coming from a bad place necessarily,
Right.
like you said, but more just from a logistic standpoint, which unfortunately can be harmful for women. But
Oh,
yeah,
yeah.
I think that is really interesting. Just so many of these issues that we're talking about, but especially career advancement and that kind
Hmm.
of either delaying a family or delaying the career. And so because of so many of these issues, I think it's so inspiring that you've launched several Facebook groups, but one in particular. Could you tell us more about why you launched this Facebook group for female psychiatrists, and how did this group provide support for female clinicians? And how does it currently?
Sure.
Because I know you
Yeah.
have a large following.
Yeah. So I launched Women's Psychiatry Group in 2015. It's a group on Facebook. It's a private group for women psychiatrists, and we just hit about 5,000. So we have a little bit over 5,000 members, which is amazing. And the group is primarily based in the US, but we do have some psychiatrists from other countries, which is really cool. So the reason that I created the group was back in the beginning of 2015. It was an unusual time for me. Before I had my son, I had a 37 week pregnancy loss of a little baby girl, unfortunately. And so this was devastating at the time. And so I took some time off from work. I was spending a lot of time on social media and actually found some support groups that were helpful. But I missed my people, right? So my people are other women psychiatrists, like those are my
Right.
people. And I looked around and there were a lot of physician mom type groups on Facebook at the time, but there was nothing just for women psychiatrists. And so that was how it came about. I really just went through and added maybe 50 or 75 people that I knew from like residency and med school, and then friends and colleagues in the city. And so it just grew by itself after that. And it still continues to grow. We're still adding members every month. I envision the group, like, first and foremost, just as a support group. And secondly, members like also use it for networking and for learning, but I would say that's really a secondary function. I feel like it's been an invaluable resource just for me. And I'll say I actually have a few different Facebook groups that I run, but really every single Facebook group that I've started has been out of a need that I personally felt. So a little bit selfish. Selfish in
No,
that.
that's great.
Yeah, but so that group has been like wonderful, I think, for me.
Hmm.
And I've heard from so many other women that they get so much out of having that space to talk to one another. And I also hear from a lot of women like they really want to leave Facebook, except for except for the fact that they have this group. So
Right,
yeah,
right.
keeping them hanging around. So it's just been great. I mean, people vent about like their day to day.
Mhm.
People ask questions about, like what's the best way to do this or that. Ask about referrals, like people that have, patients moving across the country, something like that. So looking for a referral for them. I personally have found this group and the other main group that I run, Psychiatry Network, like between those two groups, like I've found people and other people, a lot of people actually have just reached out to me to collaborate together on different, projects or presentations, conferences, even papers. And all of that has come from social media, which I think is amazing.
Yeah. Wow. So I think what you're saying is it serves as not just a professional network, but then also being able to connect with each other on a personal level, and maybe sometimes even just not feeling alone, knowing that there's other women who are going through this. It sounds
Yeah.
like it's a
Yeah.
great support network.
Yes, it really has been. I think, especially with the recent pandemic, I'm telling you, everybody has been seemingly very stressed out and overwhelmed, both in this group and just in life in general. And it's hard because even now, there's days when I have to work at home. And so I don't have my colleagues around me. And I'm used to having my colleagues around me. So like we're in constant contact through messaging and Skype and things like that, but it's really not the same as talking to somebody face to face. So I do a lot of videos between the two groups. We're talking tonight about how people have been coping with the pandemic and things that we can do to deal with it a little bit better. Yeah. And I have a speaker. So Dr. Jack Krasuski from American Physician Institute is going to be the speaker for that. So I do bring like speakers in. Well, I say I bring them in. I mean, they're in my group. So it's amazing because I have all these, like, I have access to so many people who are speakers and writers and researchers in the groups. So
that's wonderful.
Yeah. So if I think of like a specific topic, one of the first ones I did, 4 years ago was on schizophrenia. And I had one of the top schizophrenia researchers in my group. I sent him a message on Facebook and said, would you want to do a Facebook Live video? And he said, yes. So I do a lot of videos with guests. And then sometimes I'll just do a video of just me, like making an announcement or like, just whatever. And so people actually, they do feel connected both to the group and to me. I mean, when I've gone to conferences in the last year or two, people know my face, from seeing it online. Yeah. And they tell me that they feel like they know me. I'm like, oh, that's really nice. So, and I'm happy to hear that.
Yeah, I think that's wonderful. You can really build a community, even if it's online, by utilizing things like that, like video and that type of that live connection, because it's so authentic, people can connect with it. So that's great.
It's been amazing.
How did you develop and co-chair the first conference for female psychiatrists? And could you share a little bit more about that experience with us?
Sure. So the first conference that I put on was back in 2018. And the idea just came out of like, we would periodically see posts in the group talking about retreats and joking around saying it would be great to have a women's psychiatry retreat. Well, don't joke with me about like an awesome idea, because if I hear something I like, I will make it happen. So that's what I did. I worked with another psychiatrist in the group who was really interested in, making this happen, Adrienne Urich. And I had never even met her in person. So we just like initially connected on Facebook. And so the retreat that we were planning somehow turned into a conference. It was in Scottsdale, Arizona, and we had CME, and we had more women than I was expecting to come. It was amazing. And so I've tried to get the term confrete, to take off, because it was like not just a conference, not just a retreat. It was a confrete.
Yeah.
For some reason, it's taking off.
That's really cool. I like that.
But yeah, I mean, so we had talks and social outings, and considering, she and I had never planned anything like that before, it went off really without any problems. It was amazing. So it was super fun. I think everybody really had a great time.
Can you tell us a little bit more about what issues were addressed at that first conference, and then any follow-up conferences that you had? And are there plans to continue these meetings?
Yeah, so the idea behind the conference, the first one, was just kind of rejuvenating your life and your career. And so I wanted to have sessions on unique and like niche aspects of psychiatry. So public speaking, reproductive psychiatry, nutritional psychiatry. One of our most popular sessions was a self-defense session where we had a jiu-jitsu instructor present a live lesson. And so we also had a lot of activities in the afternoons and evenings, including like small group dinners, which were a huge hit at local restaurants and things like that. And then also like a downtown dessert tour that people could do. So, I mean, really, I was planning on just doing a conference and then being done. I was like, great, like I did my job, So, but honestly, I mean, people were just requesting, they were asking, when is the next one going to be? Like, what, So I did start planning a second one, and we had that in September of 2019. And that time I wanted to have like 100% like new topics, new speakers. So same format, just new content. And then one of the things, like we had activities and the dinners. And then one of the things that we added was I included professional headshots for all the attendees, because I've noticed that women just don't do this for themselves, which is crazy. So everybody got headshot done, which was really like cool. So some of the women are still even using the headshots as their profile picture. So, which is nice to see. So I do have a contract signed for next year in
Great.
2021. Yeah, it's in South Carolina in February 25th to 27th. I haven't actually announced it quite yet because I'm just wondering how this pandemic is going to be going.
Right.
Yeah, so I really hope that we can have it because I feel like everybody's been so isolated with the pandemic. It'll be really great to be able to see everyone.
What can be done to spread more awareness about gender disparities in psychiatry and just in medicine in general?
This is really affected by how we conceptualize gender disparities. And I'll give you an example. Like, I never would have considered myself a feminist many years ago. And I think that reason is because the term, at least in my mind, had a negative connotation. I'm like, oh, I'm not a feminist. And it really shouldn't. I think it should be a positive term. But I think one of the big problems is that people really just do not know all these issues. Nobody knows the full spectrum of what's happening. And I think especially in women-dominated disciplines like nursing or specialties like pediatrics and OB-GYN, the assumption is that because there are more women, they don't have issues of gender disparity. They don't have discrimination. They don't have sexual harassment. And that is actually very far from the truth based on the data.
I love that you said that.
Yeah. So it's important, I think, to educate yourself, like to actually know what the data is, and then try to educate those around you. The second thing, I think everybody listening to this needs to go and ask for a raise. You more than likely deserve the raise, and no one is going to give it to you voluntarily. I promise you that. Thirdly, think about where you're working and see, like, when you're considering a place to work, make sure that they take care of all their employees, but particularly like their women employees. And so are they making an active, concerted effort to address issues of gender disparity, or is it just kind of business as usual for everybody? So, nobody should work in an unsupportive environment or have to fend for themselves.
Right.
And then if you work in a larger system, if there are no women's committees or interest groups or anything like that, think about starting one. This can be a great place to network and to also advance some of this learning that we're talking about, and then also to make systemic changes over time. But, if you're thinking that you don't have time for this, I mean, make the time. Like, this is one of those things that it'll pay you back, so much over time by the efforts that you're able to put in it.
So we talked about this a little bit, but given the recent COVID-19 pandemic, the burden on mothers in homeschooling and just taking care of the children at home while simultaneously trying to work has been enormous. Could you address how this particular time that we're living through right now has been impacting female psychiatrists?
Yeah, this has been such a difficult issue for so many women. And I would say extremely distressing for many. Unfortunately, so many people's childcare has fallen through due to the pandemic, and with schools and now summer camps for some people are out of commission. Women, again, like, we're the ones trying to balance working from home sometimes with kind of watching the kids. I really don't even like to hear the words like childcare in reference to this or homeschooling, because let's be honest, what these women are doing is just making sure the kids don't burn down the house, patients. Like, no one's providing like great childcare. And, I would say, like, women in medicine and in psychiatry have had to make so many sacrifices, either by cutting down their work hours, having their children stay with grandparents for a period of time, or like trying to see patients while their kids are at home. I mean, none of these solutions are great. And so I just want to tell all the women who are going through that you're not alone, that there's many others going through the very same thing. And also to remember that you do not need to excel at everything right now. Like, you don't need to be both the best psychiatrist, the best nurse practitioner ever, and also like the best mom. Like, it's just not going to happen. And it's also not selfish, but actually encouraged to do something nice for yourself once in a while. Like, that's okay.
like self-care, right?
Yeah, like some self-care, just anything. I think, like, we really, really, I mean, women in general, tend to put this off so much. And I think sometimes we feel like we need permission to do it because you feel so guilty about it otherwise.
Right, right. Well, I love that you basically, connected with the people out there and letting them know they're not alone, definitely.
Yeah.
And so my final question, you shared such great information with us, but my final question is, what types of resources can be helpful during challenging times for women, such as this current pandemic?
Sure. So I have been volunteering for a physician support line. Maybe we can leave the link, but you can find it at physiciansupportline.com. I think that's a great resource. It's been personally eye-opening for me hearing other physicians' stories. And it's also made me aware that even those who are not at the front lines of COVID are still under a significant stress, because of all the changes that we've had to make and with the isolation that we've had with the pandemic. There's also something called the Disaster Distress Hotline, which is run by SAMHSA. And it's for anybody who's affected by any type of disaster, including coronavirus pandemic. You don't have to have substance use issues to use the line. I also put together an organized resource list with all kinds of additional resources one of the biggest finds in there is a large number of free children's activities. So you can actually give those out to your patients and they can do those with their kids, or you can use it for yourself. Yeah. And anybody who wants a copy of it can go to my website and shoot me a message and I'll send it to you. I'm very happy to do that.
Excellent.
Yeah.
And we will include that in the show notes as well. Thank you so much for sharing all this great information with us, Dr. Gerges, and thank you for being on our show.
Anytime, Sabrina. This was just so much fun, and thank you for having me, and I hope to talk to you soon.
Thank you.
This episode has been brought to you by the NEI Podcast. With nearly 100 episodes, you can find us on iTunes, iHeartRadio, Libsyn, and virtually any platform that you prefer to listen to podcasts. If you've enjoyed this episode, we ask that you kindly leave a review for us. Go to any of the platforms mentioned and leave a star rating or a comment. We'd love to hear from you.